I think professionally we all agree that if hand hygiene would be obeyed in 100%, we don't have to care about the surrounding of the patient, but obviously, as we know, and I don't want to elaborate too much on that, we still have challenges with compliance in hand hygiene. So the environment also plays a role. And just to share this with you, a beautiful study which was also performed by my colleagues also in Switzerland. They mounted an action cam during a night shift on an intensive care and analyzed actually how often does healthcare workers maintain hand hygiene rules during a night shift in an intensive care unit. And what they did was they analyzed surfaces close to the patient, particularly, but also surfaces far away from the patient over 24 hours. And what they found, they looked specifically for moment 1 before touching a patient and moment 2 before performing a clean or aseptic procedure. So the results was rather shocking, but a realistic result. What was seen was that hand hygiene and disinfecting hands in these moments, moment 1 and 2, they happened only in 5% before touching the patient, and only in one moment, 1% of all moments when clean or aseptic procedures were performed. This is real life data. So I think realistically, we can't say that healthcare workers maintain to hand hygiene anyway, and therefore we don't need to care about the environment of the patient because it would be irrelevant anyway. So, but clearly again, this is how infections are transmitted. You need to have a source, you need to have a target, and you have a transmission pathway. This can be direct or indirect, and particularly the indirect one pertains to surfaces, medical devices, and so on. In both situations, hand antisepsis would prevent transmission, yet if we disinfect a possible source or a vehicle, we also are able to transmit, to stop the transmission of such infections. That's a very important concept. And I always found it quite suspicious if somebody says only hand hygiene is important or only surface disinfection is important. We need to have the knowledge about the transmission of microorganisms, and then we are able to set the most effective preventive measure correctly. So coming now to cleaning and disinfecting healthcare facilities. I'm actually too old to beat around the bush, and I'm also medical director, so I'm in the management of a hospital. And I often see that somebody says something but means something different. And it's very important when we speak about cleaning and disinfecting in healthcare facilities to make it very, very clear what are we aiming at. Is the aim that the hospital should look clean, or is our aim that the hospital should be a safe place for the patient? If we do it right, we can have both. The hospital can look clean and it is a safe place. However, from an infectious disease point of view, a hospital may look dirty, but still it's a safe place. We are not happy to admit that, but that's unfortunately a reality. Now, what are the key components? And I was asked to speak about the key components for good cleaning and disinfection practice in healthcare facilities. And a couple of months ago, we published a paper together with very, very dear colleagues. It was really a joy, and I learned a lot while we were working on this paper. So we published this paper in the Journal of Hospital Infection. I'm sorry to say that because Professor Calfee is the editor-in-chief of Infection Control and Hospital Epidemiology. So next time we will publish the paper in his journal, maybe. But we have summarized here the 4 key components which we believe are are absolutely the standard which must be regarded in planning and implementing any cleaning and disinfection practice. Now, first is risk assessment. Second is the selection of disinfectants and cleaning equipment. Then, of course, the cleaning process and adequate staff training. I have to highlight particularly the training component here. And of course, the assessment of cleanliness, possibly also of microbiological safety. And I want to quickly go through these elements. If you want to know more and further about that, you can read it up in the paper where we have discussed ample all these aspects. Now, the most important concept, if you clean and disinfect in a healthcare setting, is risk assessment. What do I want to achieve? What is the current situation, and what is the aim? And basically, there are three important components which you need to take into consideration. First is the patient. So it really depends on the risk profile of the patient, how vulnerable a patient is to an infection. This can be very different. For instance, you have rather healthy, sporty patients in an orthopedic sport outpatient department, or you can have very, very sick, very ill, immunocompromised patients, for instance, typically in dialysis units. And this really, really guides you to the necessity what you have to do. Second, it's the surface risk profile. This is also a very important aspect because there is a difference if you have a surface which is adjacent to the patient or very far away. For instance, a ceiling is far less a risk surface compared to, for instance, a table next to the patient or a table where you prepare sterile medical products. So also the frequency of touching these surfaces also play a significant role. And third, of course, the pathogen risk profile. Now, the bad news is if you want to clean and disinfect in healthcare systems or settings, you need to have a certain understanding of microbiology. So you also need to understand how resilient bacteria or microorganisms are against certain disinfectants, for instance, how long can they survive in certain niches in the hospital, and how is the mode of transmission. Based on that and these considerations, you can set up a plan what is really required and necessary in a specific situation. Now, second, the aspect of the selection of disinfectants. By the way, the selection of cleaning compounds is also quite interesting, but I cannot elaborate on that. So here again, we have constructed a table which summarizes the classic the classes of disinfectants which we use in healthcare settings. You see the alcohols, aldehydes, amines, then chlorine, other oxidative compounds which are increasing today, phenolic compounds and quaternary ammonium compounds. All of these compounds, they have different physical and chemical characteristics and properties. For instance, alcohols, they have a very broad spectrum except for bacterial spores, and they completely evaporate without residues, but they're flammable, so you cannot use them on very large areas. Quaternary ammonium compounds, for instance, they have a very high tenacity, so they also stick on the surface for a certain period. Yet they have very, very good cleaning properties as well. So with these compounds, you can combine cleaning and disinfection. Unfortunately, they don't cover the full spectrum of microorganisms, and they tend rather to select gram-negative bacteria, for instance. So it's very important to have a knowledge also about the characteristics of these compounds. And my personal belief, or after many, many years, there are no good or bad antiseptics or disinfectants. There are only correctly or incorrectly used disinfectants. So keep that in mind. Finally, the principle of cleaning and disinfection process. I just summarized this. There are certain rules, principles, some of them also dogmas, because they never have been tested in a clinical study. But as a rule of thumb, this is what we also teach to cleaning staff, for instance: start from the least soiled to the most soiled area, and from the higher to the lower level. So basically, this is a rule of thumb that for practicability reasons. And there are many, many other rules. I don't want to elaborate on all of them. But also the use of detergent to remove soil and disinfect to kill germs. What is meant with that? We have to clean a surface first, because if we want to disinfect the surface, disinfecting a clean surface is so much more effective and easy than trying to disinfect a heavily soiled surface or object. Now again, you can do that, but if you do that, you really need to have very deep knowledge about the chemical and physical properties of disinfectants. For instance, the only class of disinfectant which would be able to also disinfect effectively a soiled surface would be a phenolic compound. Then again, we are not very happy to use phenolic compounds on a regular basis in healthcare settings, because over long-term exposure, there are issues with contact dermatitis and cancerogenicity. So you always need to balance matters. Very important also is training. This is, I think, the most important aspect, because again, our problem is still, particularly, and if I may say so very critically, in Europe or the Western countries, we're still very, very male chauvinistic. And mostly in most healthcare institutions, old males are deciding how to clean and disinfect. So people who never ever cleaned or disinfected anything themselves, and even at home, they have no clue what the matter is about. So we think it's very easy to do, but you need to have a very good trained staff to be able to clean and disinfect on a routine, regular mode with a very high efficacy. And I demonstrate you very briefly a very nice study by Colin, and I think Professor Calfee will also speak about studies performed by that group. This was a study which just represented the quality of cleaning before and after a training session in 27 ICUs. And what was seen that the proportion of objects correctly cleaned was significantly higher after an education session compared to before. Before it was 50%, after that it improved to 80%. Interestingly, if you look at similar graphs pertaining to improve of hand hygiene before and after training sessions, you will see it's exactly the same. And I would bet everything that 3 weeks or 1 month after the training session, the quality of cleaning decreased again. So it's a constant effort to remind and train staff who is responsible for cleaning and disinfection processes in healthcare settings. So in conclusion, I still firmly believe, and this is not because DDAPT is organizing the conference, but it's my true belief. Hand hygiene must remain the top priority for any infection control program in healthcare settings. Yet we have to acknowledge that surface disinfection and cleaning can add to the effect of hand hygiene, and maybe in some instances, the only available strategy to prevent transmission in certain situations. And of course, the intelligent combination of both will most likely yield the best result for patients and healthcare institutions. I sincerely thank you very much for your attention.
Thank you so much for that fabulous presentation. I would like to now introduce Professor Dr. David Calfee. He's Professor of Medicine and Population Health Sciences at Weill Cornell Medicine in New York, and the Chief Epidemiologist at New York Presbyterian Hospital and the Weill Cornell Medical Center. He is also the Deputy Medical Director of the Infection Prevention and Control there, and the Associate Chief Epidemiologist for the hospital. He's a fellow for the Society of the Healthcare Epidemiology of America and the Infectious Disease Society of America, and is also the newly appointed editor-in-chief for the Infection Control and Hospital Epidemiology Journal. His research interests include the epidemiology and prevention of healthcare-associated infections and multi-drug resistant organisms. Thank you so much for joining us.
Thank you very much for having me today. And this is a topic that I am very passionate about. So it's a lot of fun to be able to speak to you about a project that I worked on with my colleagues, both in infection prevention and in environmental services over the past several years. And Dr. Assadian gave a great talk, and I think you'll see, perhaps in my talk, some real world implementation of many of the principles and practices that he talked about. So I think these two talks will really complement one another. So what I'm going to talk about today is a project that, as I mentioned, we initiated here at New York Presbyterian, and this was done in 5 acute care hospitals that are part of our health system here in New York City. And it included 2 large academic medical centers, a freestanding pediatrics hospital, and 2 community hospitals. And although I'm the one who is going to be speaking to you today, it's really on behalf of the entire team that I'm talking today. And particularly, I'd like to acknowledge our research team, particularly Liz, Daniel, and Elena, who did most of the legwork on this, as well as the entire infection prevention and control department. And last, but certainly not least, our colleagues in the environmental services department, particularly the frontline EVS workers who play a critical role in making our hospital a safe place, and who have been enthusiastic participants and partners in all of this work. And I'll begin by showing some data from other investigators that I think demonstrate why we've chosen to focus on the hospital environment in some of our work to prevent pathogen transmission and healthcare associated infections. Many studies have shown that the occupied environment is frequently contaminated with pathogens. And for example, investigators have shown that if you sample surfaces, high touch surfaces that we heard about in the last talk, in rooms of that are housing patients who are colonized or infected with Acinetobacter baumannii, you can find Acinetobacter on about 42% of those rooms and on those surfaces. That goes up to about 3/4 of rooms housing patients with MRSA, and studies have shown environmental contamination in 100% of the rooms that they sampled that were housing patients with C. difficile infection. And those data may not be surprising to anyone on this Zoom meeting here today. In fact, that's why it's recommended that we clean and disinfect hospital rooms on a daily basis, and certainly after discharge. However, there's a significant amount of evidence that indicates that important pathogens are frequently recovered from the environment even after cleaning and theoretically disinfection has been completed. For example, one study conducted over 3 years in 9 hospitals and 2 long-term care facilities that found that in the rooms of patients who were colonized or infected with one or more known multi-drug resistant organisms, that MDRO of interest was recovered from high-touch surfaces in those rooms after daily cleaning 34% of the time. And even more concerning, those same organisms were identified 18% of the time after discharge cleaning, meaning that the room had been deemed ready for another patient to occupy that space. And that environmental contamination that can persist even after hospital discharge puts the subsequent occupants of that room at risk. In fact, several studies have shown that the patients who are admitted to rooms in which the prior occupant was colonized or infected with a particular pathogen are significantly more likely to acquire that pathogen than are patients who were admitted to rooms in which the prior occupant was not colonized or infected. Overall, there is about a twofold increased odds of acquiring colonization when admitted to such a room. And this has been seen across studies of a variety of pathogens, including C. difficile, Pseudomonas, Acinetobacter, MRSA, and VRE. And I think all of these findings really beg the question, why aren't our cleaning strategies eliminating these pathogens from the environment? And of course, there are many potential explanations, and I suspect that multiple factors contributed to those findings, but a critical contributor is that environmental surfaces are simply not being cleaned. This is another study from Phil Carling's group, where they conducted assessment of the healthcare environment, high-touch surfaces in 36 hospitals following discharge of patients. They used a fluorescent marking system that's easily removed from surfaces when it's physically cleaned. They applied that marker to high-touch surfaces after the patients had been discharged, but before discharge cleaning had been performed. They then came back with a black light after discharge cleaning had been done to see if the fluorescent markers had been removed. And what they found was that 52% of the markers were still present after discharge cleaning, showing that those surfaces had not been touched or properly cleaned during that manual cleaning and disinfection process. Now, I recognize that all that data is fairly depressing and perhaps overwhelming to consider. But on a more positive note, we know that when we do it right, cleaning and disinfection can significantly reduce the risk of environment-related transmission of pathogens to our hospitals. For instance, a hospital in Boston showed that by enhancing their cleaning and disinfection process, they could lower the risk of MRSA acquisition by 25%. And in fact, they totally eliminated that increased risk of acquisition among patients who were admitted to rooms in which the prior occupant was colonized or infected with MRSA. And we've also seen other groups show significant reductions in hospital-acquired C. difficile infection in association with improved cleaning and disinfection. So in our work, the first thing we wanted to do was understand what was happening in our hospitals. How were things going now? How effective were the discharge and daily cleaning processes? And when I think about assessing the cleanliness and safety of the healthcare environment, it reminds me of the parable of the blind man or the blind man and the elephant. And in order to truly understand that beast and what it really is, we really have to assess it from multiple angles and in multiple ways. And if we apply this analogy to our healthcare facilities, there are multiple ways that we can and probably should assess cleanliness and safety. If we look at things in only one way, we may miss something important. And chances are, if we do this thoroughly, we will probably all find that we have some opportunities for improvement in our facilities. So one of the things we did early on in our project was an objective assessment of cleaning practices. We used an ATP detection method that measures the amount of organic material on the surface, essentially a marker of cleanliness or the effectiveness of cleaning. We sampled high-touch surfaces in patient rooms before and after cleaning to allow us to determine if the surface was effectively cleaned during that process. And what we found was that discharge cleaning was actually pretty good, but we had some opportunities for improvement with regard to daily cleaning of occupied patient rooms. Now this graph, on the x-axis, you see a variety of surfaces that we sampled, things like bed rails and overbed tables and visitor chairs and parts of the toilet. The y-axis shows the relative light units, which is a marker of the amount of ATP or organic material present, with higher numbers indicating a greater burden. And the bars in green show the load prior to cleaning, and the bars in blue represent the organic load after cleaning. And what you see is that we saw significant reductions down to passing levels for items like the toilet flush and the toilet seat. We didn't see significant changes, however, for other surfaces, and most remained above what was considered to be a passing level at that time. And notably, it was the items that were closest to patients, like the bed rail, the call box, the visitor chair, that had the highest pre-cleaning ATP burden, as well as the smallest reduction after daily cleaning. And this probably indicates that those surfaces were not being touched at all. So with that information, we knew we had some work to do. And sadly, I think a very common approach to quality improvement in environmental services is to simply yell louder at the people who are responsible for cleaning and disinfection, presumably under the assumption that they aren't doing it correctly because they don't want to. But in reality, I think it's much more complex than that. And in fact, I would argue that maintaining a clean and safe healthcare environment is one of the most complicated things that we do in healthcare, on par with things like central line insertion, use, and maintenance, for which we use a much more evidence-based and methodical approach to improvement. So this is the approach that we decided to take to address our environmental contamination. As I mentioned, and as Dr. Assadian mentioned, maintaining a clean and safe environment is a very complex process. In addition to the cleaning and disinfection process itself, there are numerous other factors that we have to consider. It has to be done frequently, daily at discharge, on transfer. It often occurs in occupied spaces. There are sick patients present. There may be visitors or healthcare workers present. There may be the fact that different people have different expectations and competing priorities with regard to cleaning and the amount of time it takes to properly clean a room. And finally, all of this relies on many people and human behavior. Now, human behavior by itself is complex and influenced by many factors. And I'm by no means a behavioral psychologist, but I think that as we embark on quality improvement work in any area, but particularly environmental services, it's important to recognize some of the major determinants of human behavior and to take these into account. So in one theory, one of the three main determinants of behavior is the individual's attitude toward that behavior. As it relates to cleaning and disinfection, things such as awareness and acceptance of responsibility for cleaning certain items, an understanding of the impact of cleaning on patient outcomes, like hospital-acquired infections, an outcome or impact on the worker, him or herself, such as toxicity due to exposure to chemicals, or perhaps risk of getting infected by being near sick patients. The second determinant is the control one perceives oneself to have over the behavior. Does the individual have adequate skill and training to do it properly? Are they given adequate tools, equipment, supplies, and time? Are there significant systemic workflows or other barriers that prevent them from doing it properly? And finally, there's the subjective norm, or what are the expectations of one's supervisors and one's peers? If no one else seems to care about the behavior, I'm probably less likely to care about it myself. And I'm certainly less likely to implement it, particularly if there are challenges or barriers that I need to overcome to do it. So one of our first priorities was to identify and understand the barriers that stood in the way of the behaviors and the outcomes that we wanted. And we took a few different approaches to doing that. First, we wanted to see firsthand what it was like to live the life of a frontline environmental services worker. We wanted to have objective, impartial, and non-judgmental observations. And we thought carefully about who should do that. We decided that I wasn't the right one to do it. Many of the staff already recognized me as one of the physicians in the hospital and a hospital leader. So we embedded some of our younger research team members into the frontline EVS team. They were certainly probably less threatening. They didn't know who they were younger, and they could really just hang out with the EVS workers during their shift, ask non-leading questions, and just get a real sense of what happens on a day-to-day basis. And while that shadowing experience was great, and it did allow us to get a lot of useful information, it gave us the perspective of only a few frontline workers. So we invited all of our EVS workers to participate in a survey about their knowledge, their attitudes, and their practices related to environmental cleaning and disinfection and infection prevention in general. And we had a good response rate. About 45% of all of our EVS workers completed the survey. And between the shadowing and the survey, we got some really useful and actionable information. We found out that there were a number of opportunities for education, including concerns about personal safety, a lack of clear understanding of the role of the environment in infection transmission and HAI prevention strategies, unclear expectations of the frontline EVS staff. We also learned that our staff were really eager for more constructive feedback on their performance and how they were doing. And we identified several important workflow barriers, things like clutter in the environment, frequent interruptions by healthcare personnel, lack of clarity regarding cleaning responsibility, pushback from patients, particularly with regard to daily cleaning, with concerns such as the odor of the disinfectant, or just wanting to be left alone because the patients themselves didn't necessarily understand the importance of the work. And finally, we learned that many of our EVS workers were concerned about disturbing patients. These patients were sick in the hospital, and they didn't want to disturb them in order to get near them to clean their environment. And finally, we found some larger issues, such as a lack of appreciation and respect that many of our EVS workers and colleagues felt. We were excited to see, however, that 72% of all of our participants expressed great interest in learning more about these topics. So we did a number of things to address many of the challenges and barriers identified. And I'm going to talk about the education and culture change intervention that we designed with our frontline team. And we did this to try in using adult learning theory. We included them in planning and evaluation. We took into account their previous experiences and wanted to make this immediately relevant to their job. We tried to be interactive. We used audience response systems. We did role playing, demonstrations, group discussions, and had some Jeopardy style questions that allowed them to choose the topics that were of greatest interest to them. And what came out of this was a 5-part education series that we called Cleaner is Safer, EVS on the Front Line of Infection Prevention. This was presented to all shifts on all 5 of those hospital campuses. There were a total of 65 sessions with an average of about 350 participants per module. And then we had a couple of refresher modules over the course of 6 months after that. And those covered timely topics such as influenza vaccination in the fall, as well as some quick reminders of key topics. And as I mentioned, we really tried to decrease text and jargon and specialized language and really focus on audience engagement and using images and graphics and demonstrations. This table outlines the key topics that we covered during each session. You can see we had a general introduction to infection prevention. We talked about hand hygiene and isolation precautions and the whys behind many of the things that we asked them to do. We talked about discharge and daily cleaning with demonstrations of contact time. And then we had a session on overcoming frequently encountered challenges and barriers to give them an opportunity to talk about their challenges and to brainstorm and work together to come up with effective solutions to address those. And then to assess this, we used the Kirkpatrick's 4 levels of training evaluation so that we could really see if our intervention had the outcomes that we wanted. And so the first couple of outcomes that we looked at were reaction and learning. So 1, did people like it? And 2, did they learn something as a result of the training? And you can see we were very pleased that people really tended to like or indicate that they liked these presentations. They thought they were useful and they would recommend them to colleagues. And that's great, but we also wanted them to learn something. And in fact, people did indicate that they had a better understanding of how daily cleaning prevented transmission of germs. They were more confident in their ability to perform hand hygiene and to don and doff PPE. And I thought what was one of the most exciting things about all of this was that 92% of our participants by the end of this series considered themselves to be important members of the IPNC or Infection Prevention and Control team. But did they change their behavior with this information? And so we looked again at our daily cleaning pass rates using ATP technology. And you can see that we had significant improvements in our cleaning of many surfaces, particularly those that had we'd done so poorly on before, immediately following the intervention, including those surfaces like the bed rails, the call box, the visitor chair, where we had really not done well at all prior to the intervention. And as Dr. Assadian mentioned, there's frequently a drop-off immediately after the end of an intervention, and Dr. Carling's studies have shown that. So we were hopeful that with this different approach to training, including giving them more of the why behind and not just the how to do things, and with those subsequent periodic follow-up sessions, that we would be able to maintain that improvement. And in fact, we showed that we were able to do that at least a year after the end of the intervention. So we're really excited about this, and we'll see if that continues into the future. But the most important outcome we wanted to see was that, did this change our risk of infection among our patients? And certainly this is hard to measure because these hospital-acquired infections are multifactorial in nature. But we looked at our hospital onset MRSA bloodstream infection rate and C. difficile rates. And we saw in temporal association with our interventions that we did see a significant reduction in C. difficile infection and a non-significant, non-statistically significant, but notable decrease in MRSA bloodstream infections. And certainly I can't say that these reductions were due to or caused specifically by the intervention. And I think that's okay. We often know, or we know that in many cases, infection prevention interventions are most effective when they're done in combination with other interventions. So whatever caused this reduction, I'll take it. And so I'm going to stop by just saying we're really proud of all the work that we did together as a team. We learned a lot and things got better, but we can still do better. And I think we do need to continuously ask ourselves if we're doing all that we can to keep our patients and our communities safe and healthy. So with that, I'll stop and we can move to the Q&A session.
Thank you so much for your wonderful talk, both of you. So we have a number of questions that were already submitted in advance. And so I would like to read a few of those for you now. So the first one is, can you speak a little bit about the difference between microfiber and disposable cloths to clean and disinfect surfaces? Which do you prefer, and what are the pros and cons?
Well, I'm happy to comment on this very briefly. We actually did a study on exactly this question a couple of years ago. In a nutshell, if you have a new microfiber cloth compared to, let's say, a cotton cloth, the efficacy to decontaminate a surface in the terms of picking up particles from a surface is significantly higher with a microfiber cloth compared to a cotton cloth. However, after 10 reprocessing units, washing and drying these microfiber cloths, you already can measure that the efficacy is decreasing. And after 50 reprocessing cycles, the efficacy is exactly the same like a cotton cloth. Yeah. So yeah, there is a difference. However, you have to think about repeatedly replacing this expensive resource.
Thank you so much. Any other comment? Okay.
That was great.
Sorry. Okay. So another question speaks about that their hospital received a disinfection robot as a donation from the European Commission, and that the robots are UV disinfection. And what is your experience with implementing, well, they were speaking about a specific robot, but automated UV disinfection systems in general?
I can start with this one, but feel free to jump in and answer. So our personal experience had been that logistically it was quite difficult. And I think the one thing I'll start off by saying is that these are adjuncts to basic cleaning and disinfection, the manual process. They don't replace cleaning, as we heard in the first discussion, that cleaning is an important part, and you can't get can't get good disinfection if you haven't adequately cleaned something. So these are added on top of a basic cleaning and disinfection program. And I think in the laboratory, many of these systems, UV and some of the others, are shown to be able to decrease contamination. I think we haven't seen a whole lot of clinical data to show an impact on those in clinical infection. A few studies have been done, and so the results are a little bit mixed. But I think if you are trying to implement something like this, the logistics, you really have to think through in terms of the deployment of the device, particularly if you only have one and you have a busy hospital with lots of discharges. You might have to prioritize which rooms are going to get that treatment, as particularly if you have a high turnover rate and you're really trying to move patients through the hospital, because it can add a significant amount of time to that room turnover process. So that's been my experience. I'll see if Dr. Assadian has anything else to add.
It's exactly the same. Basically, I had a couple of years ago, it was really fun visiting the Osaka Medical Center. And in Japan, the culture is very, very, very open to technological innovations and systems. Interestingly, the colleagues told me that, yeah, they do use robots for many different tasks, particularly also for transportation of samples and so on. One of the problems or issues they had, that they had to implement an own repair and facility maintenance unit to take care of these robots. Now, all of that can be solved. The biggest problem is, unfortunately, that these technological assistance systems are called cleaning robots, while in reality they are maybe, if they're well constructed, the purpose is to disinfect surfaces. So my chief financial officer, for instance, frequently comes with glossy brochures and says, hey, look, we can replace cleaning stuff, which is really more expensive than these devices. And I tell him, no, unfortunately, we cannot, because we need a cleaning robot. Yes, we immediately would purchase that. But it's, as far as I know, it's not available, and it's also no pleasant narrative to tell the patients. Look, we know that your patient room looks really dirty, but the good news is it's disinfected. That doesn't work.
Definitely. Another question: for the materials that you use for teaching the environmental, excuse me, the environmental service workers, and for any visual aids, what sort of level of vocabulary or complexity of teaching material are you using?
Yeah, what we have done, and I will say, our training that I talked about wasn't the hands-on detailed work training of how do you actually do the job. It was more the bigger picture of the why and some of the systematic barriers. That said, I think we have worked closely with our EVS team on some of that other training. And here, at least, the education level is quite wide, variable among the frontline EVS team. We have people who finished high school, we have people who have been to college, and so it's quite a wide range. And so we really try to aim for most of our education, whether it's for patients or our EVS workers, somewhere between like a 5th to 9th grade, I think, level, and tending to use a lot more in the way of visual images, fewer words, demonstrations, things like that. And we also, at least here in New York, we have languages. We have to think about different languages, particularly mostly English and Spanish are our most common ones. So for instance, our survey was available in both English and Spanish. So that's kind of where we aim things.
Yeah, so this idea of really adapting tools for the intended audience. Thank you so much. Next question is, what is the recommendation for disinfecting surfaces or air through fogging or vaporization devices? And which of these devices have the efficacy to eliminate pathogenic bacteria and viruses with materials compatibility?
Oh, that's a fantastic question, and I'm very happy about that, because the core of the question actually is what do we know about treating air? In fact, we know a lot about surfaces. We know even more about how to disinfect hands, how to disinfect surfaces, how to disinfect and reprocess medical devices and instruments. But the reality is, if we are very, very open, during the past 6 decades, we really have not scientifically looked into air as a vehicle for transmitting pathogens. And really, SARS-CoV-2 and the current pandemic opened this field completely newly. We have to rewrite certain concepts pertaining to droplet and particulated transmission, for instance, which we had in the past. And I think this is a very important field where we have to come together as a scientific society, all the scientific societies and people working in academic infection control and prevention. And we have to very objectively, on the basis of research and science, investigate these questions. What's happening now is that many, I wouldn't say gold diggers, but many companies which see an opportunity, there is something we could do. And many of them really think they can attribute also to the safety of their societies. They come with technical solutions, but we even don't have internationally agreed standard testing norms for these devices. So yeah, we have to develop that. And we have to invest more time in studying these questions. So that's the experience. I only can look at a lamp or a filter or a fogging device, and I can look at some in vitro data, but how can I translate that information into the clinical practice?
Thank you. And what would you consider to be the optimal frequency of training for environmental service workers?
I think that's a great question. I don't think mine has the exact right answer. I think some of it is, you definitely have to do that initial training so that people know what they're expected to do. And that's probably the most intensive training. And then you need to kind of come back with small tidbits along the way to remind people of the things to do. We've gotten into doing periodic competency assessment, sort of as an assessment to see how people are doing and an opportunity to retrain their specific opportunities for improvement. And then I think coming back periodically and talking to the larger group about key things, new devices, new chemicals, new products, and how those fall into the workplace. And I will say that having built this relationship with the frontline team during our educational initiative was invaluable during the COVID pandemic because they knew who we were. They had developed more of a trust with us. And so when something new comes into the healthcare system, some new pathogen, some new concern, a new vaccine, we were able to actually already have that level of trust and understanding. And then we could, I think, have more effective communications about their concerns and fears and questions.
Perfect, thank you. And then I had a comment from one of the participants that spoke about that her hospital during COVID started sort of looking at sort of ignoring the basics and participating in this gold rush of sort of quick fix, high-tech solutions, and that the basics were getting neglected more than they should have been during this time. Is this something that you've seen also in your own institutions or maybe internationally? And how do you think is the best way to sort of address this if it's a problem that you've seen?
I think we all made the same experiences. So during the past 18 or 20 months, I was overwhelmed with, I would say, some 120 different offers from companies coming to our healthcare trust. And they all said, please buy this because this will prevent transmission of SARS-CoV-2. And then I had to make an assessment if this is effective, should we buy it or not? Very, very difficult aspect. Maybe just to share with you, the easiest way to sort out those technologies which possibly are not very effective is when I ask the manufacturers, so would you be willing to spend a night in a room with a COVID patient where your device is running without any masks? So most of them said, no, we wouldn't. I think that's the difficulty, you see. But then again, the comment is right. There is a significant danger that we might overlook 1, 2, or 3 technical solutions which really have an impact, and we simply say, oh, all of that is hoax, it doesn't work. That's not true. We need time to come up with standardized testing systems, to agree on how to assess and sort out these technologies. And what I did now in my hospital is that we provide a standardized testing environment in a certain building here. So where the air handling units and waiting area and the cath lab can be used for standardized measurements. Having said so, what we can measure is physical parameters like temperature, relative humidity, total particle count, total bacterial count, and so on. But then again, these are only measurements showing, is there any measurable effect, yes or no? We still cannot say how much can we prevent or protect people in a room from airborne transmission. We don't know.
Perfect. Thank you so much. And we still have a number of questions, but we're unfortunately out of time. So I wanted to thank you again both so much for joining us and for giving us these great talks. Have a great afternoon.
Thank you very much. I really enjoyed that session. Thank you very much.
Bye-bye.
Thank you. Goodbye.